Hello, my name is Mohsen Sharifi, and it's an honor and a privilege to be able to present in this year's virtual presentation series of CVI. I've been charged to talk about all you need to know about acute and chronic venous disease. Obviously, this is a very wide topic, and we'll be focusing on the main elements of this as much as possible. There are over 80 million individuals in the US who have some form of venous disease, and over 13 million have chronic venous insufficiency. The peak incidence in women occurs at an earlier age, between 40 to 50, and for men this is about 2 decades older. Over 30% of those over 45 have some form of venous disease, and only, regrettably, 4% get treated. The annual cost is staggering at over $3 billion, with annual workday loss of 2 million. The types of venous disease can be anywhere in the body, although we are focusing on the lower extremity and pelvic venous disease. It can involve the superficial and the deep venous systems. In the lower extremities, it can involve the great saphenous and the small saphenous veins, the accessory veins and the perforators. It can involve the deep system, the infrapopliteal, the femoropopliteal, iliac veins, the IVC, even the upper extremities, and this splanchnic circulation. The pathophysiologic classification according to the SEEP can summarize this to reflux, which is denoted as PR, obstruction as PO, combination of reflux and obstruction, which would be RO, and if there is no identifiable pathophysiology, although there is a reason, but we simply don't know, as PN. So DVT is only one etiology of venous obstruction. Both obstruction and reflux would ultimately lead to ambulatory venous hypertension, which sets off the entire inflammatory cascade leading to subsequent problems. So the main pathway would be inflammatory response, followed by an increase in the interstitial hydrostatic pressure. This would be a vicious cycle, and an increase in the ambulatory venous pressure. This graph shows a normal individual that with minimal activity, the venous pressure drops rapidly. However, in those who have venous hypertension, there is only minimal reduction with pump function and the calf pump activity. Ambulatory venous hypertension can lead to vascular extravasation and leukocyte and endothelial activation, which ultimately lead to changes in the skin, dermal fibrosis, ulceration, and lymphatic microangiopathy. Almost every element within the blood can be a contributing factor, from red cells, leukocytes, macrophages, monocytes, and fibroblasts as well. The agents and the proteins and the molecules are variable. This is just a few of those: the intracellular adhesion molecules, the vascular cell adhesion molecules, CD54 and 106, activation of the transient receptor potential vanilloid channels plays a major role. Any form of the cells within the bloodstream can be a contributing factor. The cytokines, tumor necrosis factor, transforming growth factor beta, interleukins, MMP, Emprin, or the extracellular MMP inducer, the MAPK, the mitogen activated protein kinase pathway, all play a role in this cascade. There is also genetic contribution. We know that hemochromatosis gene, the HFE gene mutation, can lead to the formation of venous ulceration and also has a role in its healing process. Mutations in factor 13 gene and the ferroportin gene, known as the FPM1 gene. Venous leg ulceration is a significant morbidity seen in patients with venous disease. It occurs in 1.5% of the general population, and if you look at patients who are over 65 years, 5% of them have some form of venous leg ulcers. It is not just morbidity. Venous disease can be lethal. Phlegmasia Cerulea Dolens is an example that carries over 40% mortality if left alone. And amongst those who survive the disease, there is a high rate of amputation. Obviously, there is venous thromboembolism, the third leading killer in the United States. Over 800,000 are diagnosed annually, but many would go undiagnosed. There are 600,000 admissions per year, and the annual mortality is estimated at over 100,000, probably around 150 to 200,000. And the sad thing is that these are preventable deaths. The clinical forms of obstruction can be multiple. It can result or lead to DVT, any form of outside pressure. It can be a tumor, it can be May-Thurner, adenopathy. Venous stenosis can occur secondary to radiation. Any direct or indirect venous damage that can be imparted in orthopedic surgery. This is unfortunately an underdiagnosed etiology. Many patients who have orthopedic surgery with arthroplasties in their hip, or their lower vertebrae, they can develop venous obstruction and symptoms without anybody knowing what's going on. Pelvic, abdominal surgeries and placement of AAA grafts can also damage the central veins. Reflux is not only limited to the larger truncal veins. It can occur at the microcellular level. This is an electron microscopy that you can appreciate the distorted and meandering anatomy of the venules at this level. There's a technique known as retrograde venography corrosion casting, which can give a cast of the microcellular level venules, and you can see that varicosities have developed very similar to what you see macroscopically. Orthopedic hardware play an important and underdiagnosed role. This is somebody with right hip arthroplasty. Actually, this was a left. The patient was in a supine position. And you can appreciate the significant obstruction and its treatment after stenting. This is another patient with the damage to the iliac veins after arthroplasty. This is another patient that on initial venography you would not appreciate that much problem, but once intravascular ultrasound is performed, the pancake effect is noted, and by no way you could have picked this up on a regular venogram. Hence the necessity of performing intravascular ultrasound in these patients. This is a patient who had received radiation with several years subsequent to that developing lower extremity symptoms, and he was successfully treated with endovenous stents. However, although IVUS is paramount to such intervention, there may be times that you do not have access to IVUS. My experience suggests that there are hints to presence of significant stenosis, even if the venogram looks normal. If you have deflection of your guide wire, that points to some form of obstruction, maybe a web, some form of a shelf, or inherent obstruction in a pancake format. If the cephalad diameter of the vein is smaller than the caudal diameter, that's also a signal to severe stenosis. Occasionally you may see color flow aliasing, but not always on external duplex. Pressure difference of over 2 to 4 millimeters of mercury has been reported, but it's not reproducible. And if you find it, though, it's an indicator of severe obstruction. One other thing that I've realized is that if the patient develops pain during balloon inflation during your intervention procedure, it suggests that the outcome is going to be good. Once you put the stents, these patients tend to do really well after intervention and stenting. In patients with ulcers, there is a higher prevalence of reflux than obstruction. However, if there is obstruction, those patients have a higher rate of developing venous ulcers and a much faster progression rate. And the flip side is that they respond also faster to relief. Dr. Raju, in a seminal paper in 2010, demonstrated that if you have the combination of both obstruction and reflux, and you address only the obstruction part, the patients do real well despite having persistence of reflux. They showed that in a cohort of patients who were really advanced in their venous disease, C4 and above, 25% actually had ulceration, and 100% of them had reflux in the deep veins. Freedom from ulcer recurrence of healed ulcers in 5 years was 88%, and they had significant improvement in their quality of life. This is an acute presentation, and what we want to do is make sure this doesn't occur. As far as deep vein thrombosis and the role of percutaneous endovenous intervention, or PEVI, this concept has undergone a roller coaster change over the last decade. And unfortunately, the practitioners and the family practitioners and the internists have been getting mixed messages about this. With the publication of the ATTRACT trial, the conclusion was really, in my opinion, misleading. And I think it was with a heavy heart that the investigators had to come to this conclusion because of the certain criteria they had defined prior to the study. They concluded that among patients with proximal acute deep vein thrombosis, doing intervention in addition to anticoagulation did not lead to a lower risk of post-thrombotic syndrome, but led to more bleeding. So whoever reads this would come to the conclusion that it's a bad thing, it's a negative study, but it's really not the case. And the Europeans immediately published a rebuttal saying that, in our opinion, for the reasons described above, the ATTRACT trial does not reflect the current practice in Europe. So the physicians got confused, and then there came other papers trying to delineate the actual advantage that the ATTRACT trial demonstrated. But it's really hard to unring a bell when it has been done. We know from the natural history of iliofemoral DVT at 5 years that there is a high prevalence of venous ulceration at 15%. Venous claudication can occur around 20-25%, with venous insufficiency and reflux developing in 90% of the patients, with a high risk of post-thrombotic syndrome. The ATTRACT data demonstrated that major bleeding was higher in the interventional arm, but the leg pain and leg swelling immediately improved. And one has to consider that it's not just PTS which is important. Patients' quality of life, pain, swelling are also important in their well-being. And if you look at the iliofemoral component in that trial, moderate to severe PTS was significantly reduced, and severe PTS was also significantly reduced. So the authors tried to modify their initial negative conclusion by stating that intervention can be considered in patients less than 65 years old with acute iliofemoral DVT who are very symptomatic and at low risk of bleeding. Their results was also mirrored with the recently published CAVA trial. This was published in Lancet Hematology in 2020, and they looked at PTS developing at 1 year. The authors used ultrasound facilitated catheter-directed thrombolysis in 77 patients, and they had 29% post-thrombotic syndrome, and in the control group 35% developed PTS, and the p-value was 0.42, and there was therefore no difference. To submit to you that what the criteria used for defining PTS was misguided. Now everybody knows that Vialta score is a good assessor for PTS, but it is also an assessor for other things. In other words, patients who do not have PTS, their Vialta score can be high. You can start with a Vialta score of 10 to 12 because they have venous insufficiency. And unless you define that at the beginning, what are you going to do with those patients? You will ultimately come with a high PTS score. We did not use the Vialta score in the Torpedo trial. We defined what we called PTS, and this was a major source of criticism to our study, but we did demonstrate that in the patients undergoing intervention, recurrence of VTE was less, and development of PTS, both in the short term and in the intermediate term, was less with PEVI. In the CAVA trial, they showed similar findings. PTS was less in the interventional arm, as was reflux. The iliofemoral patency, however, was equivalent. And obviously, we know that such patients get almost immediate relief with intervention. A word about compression stockings. Again, this has been a source of misconception. With the SOX trial, the conclusion was that compression stockings do not reduce the risk of PTS. But this has been, again, another misunderstanding amongst practitioners saying that compression stockings should not be applied. Compression stockings must be applied in a variety of conditions. Even in patients who have no benefit from PTS, their symptoms get better once they wear it. In patients who undergo endovenous ablation, they should wear it. That's a 2C indication. After sclerotherapy, a 2C indication. For leg ulcers, it's even higher. The indication is 1B. And another misunderstanding is in mixed disease. In other words, patients having PAD and venous reflux disease, compression stockings should be avoided. It should be avoided only in certain conditions, in cases that have moderate to severe PAD, not mild to moderate form. In other words, patients who have an ABI of over 0.5 and an absolute ankle pressure of over 60 millimeters of mercury, they still qualify for compression stockings. Now, going back to acute DVT, the guidelines of the ACCP in 2012 and 2016 recommends against it. It says in patients with acute proximal DVT, we suggest anticoagulant therapy alone over catheter-directed thrombolysis. I think this is a disservice to the patients, because those who have iliofemoral DVT, they do far better with intervention. There is a qualifying remark, even with this recommendation, saying that patients who would like not to develop PTS and are willing to accept the potential risks may choose intervention over anticoagulation alone. So it's kind of a neutral comment rather than a recommendation. If you look at the AHA guidelines, there's a class 1C indications for Phlegmasia, Cerulea, Dolens. And in patients who have rapid thrombus extension despite anticoagulation, there's a 2A indication. The Society for Vascular Surgery also mirrors that indication. They suggest a strategy for early thrombus removal in patients who have a first episode of acute iliofemoral DVT, and if their symptoms are less than 14 days and who are at a lower risk of bleeding. The Society for Interventional Radiology, or SIR, also mirrors the same recommendation. One should know, at least in my experience, that if a patient comes to you with acquired unilateral edema, meaning that it wasn't there before, and now, after months or after years, they have progressively developed one leg being larger than the other, and nobody could figure out what's going on, they almost always have iliac vein stenosis. Again, this is my experience. These are patients who have symptoms and their leg had become larger than the other side, and for years and even decades they were told to go and wear compressions, take diuretic therapy, do activity, and so forth. And obviously it's a progressive disease and leads to significant morbidity, and their life can become miserable. This is a more severe form, and the patient had developed lymphedema. One point about lymphedema and venous disease go hand in hand. One can lead to the dysfunction of the other system, and you almost always find them together. With the recent publications and data, lymphedema is a cornerstone of venous pathology, and by the time the patient gets to you, they have some form of lymphedema as well. This is the same patient with significant obstruction in the iliac vein, and this is it after stenting. Another patient before and after that was having unilateral edema for decades. Placement of AAA ELG can lead to problems with the truncal and central veins. Here the inferior vena cava, within the inferior vena cava, thrombus has occurred. There is damage to the iliac vein as well, and they can be successfully treated with percutaneous endovenous intervention. So in conclusion, venous diseases are very common. They are undiagnosed or underdiagnosed, and they can impart significant morbidity and even mortality. And what I would like to propose is that the indicators of PTS, such as the Vialta score, should be revisited in future studies, because using the old system of assessment has caused more problems in interpreting the data than advantages. I would like to thank you for your attention, and have a great day. Thank you.